Good morning, everyone. It's a special opportunity for me to be able to introduce and welcome Dr. Ben Elder to SDSF. Dr. Elder is a professor of neurosurgery, orthopedics, and biomedical engineering at the Mayo Clinic in Rochester. He started his career at Yale, where he got a bachelor and master's degree. He got an MD PhD at the Baylor College of Medicine. And he did a residency in neurosurgery at Johns Hopkins, after which he also did an orthopedic fellowship with Dr. Cal Kabash. He is really a world expert on bone mineral density optimization and bone health, with numerous papers and many national and international talks. He's also a phenomenal surgeon, really, really good guy, and has been an amazing mentor to many at Mayo, including myself. So thanks for joining us, and welcome, Dr. Elder.
Perfect.
Welcome.
Yeah, thank you. So excited to talk to you about bone health optimization. All right, so these are my disclosures. The Amgen affiliation probably does have some relationship to this talk. Otherwise, everything should be unrelated. So just wanted to start off with a case example, which I'm sure is pretty similar to many of the patients that you guys see. So this was a 65-year-old woman that I treated several years ago who had a history of diabetes, BMI of 39, and osteopenia for 10 years that had never been treated. She fell down the stairs a year prior and had an L1 burst fracture. This was treated at a local hospital with a thoracolumbar laminectomy as well as instrumented fusion. And then 2 months after surgery, the physical therapist noticed that she had a progressive bulge at the top of her incision and was unable to stand up straight. And then she began seeing me about 6 months later, and at that time had 3 months of progressive lower extremity weakness and intermittent bowel and bladder incontinence. On her exam, she had a significant forward-leaning posture and a focal kyphosis at the top of her incision, and some protrusion of the hardware through some protrusion of the hardware, though her skin was still intact over it. She had full strength in the upper extremities and mild weakness in the lowers, but clear upper motor neuron findings with hyperreflexia in the lower extremities. So this was the original fracture that she had with a pretty typical L1 burst fracture, and had the typical 2 levels up and 2 levels down stabilization and very wide laminectomies for treating it, nothing done ventrally. And then when she came in to see me, this was her films where she had almost a 60-degree focal kyphosis across that segment and a severe sagittal plane deformity. And then this was right at the conus level where she was draping the cord across it. There is significant mobility associated with it, as it did correct a fair amount on the supine films. This is the MRI showing on the neutral position. There's maybe not direct compression, but there is a fair amount of ventral draping of the conus across it, and clearly dynamic compression. And then this was the CT scan. And so there's still that retropulse bone fragment within the canal. And then looking at all of her screws, she had significant failures at every level where the pedicles were almost completely eroded from screw pull out with significant halos around them. And then just showing some of the axial cuts and the very wide laminectomies with no real joint left at several of the levels. So looking at her T-scores, her lowest T-score is still minus 1.8, which would put her in the osteopenic range. But if we looked at her Hounsfield units, at T10 level, it was 63. And then looking down in the lower lumbar spine, it was 30, which is in the severely osteoporotic range. So as we'll talk about later, the Hounsfield unit, the set point is 0, which is the density of water. And so hers are just slightly more dense than water. So you can clearly see why things failed in her case. So some of the challenges presented by this case are osteopenic T-scores, but she's clearly severely osteoporotic with almost an immediate failure of her construct. And then how do you balance the time to optimize bone health with this dynamic conus compression, which resulted in some lower extremity weakness and thoracic or conus myelopathy? And then how best would you reconstruct with no real pedicles left from T11 to L3 and no anterior column support? So for her, I started her on romosozumab, which is one of the newer agents that we'll talk about. And she remained relatively stable neurologically, and I followed her closely and ended up treating her for 9 months before surgery. I also had her try and lose some weight and got her BMI down to 34 during that 9-month period. She underwent a 2-stage surgery with, or actually 3 stages with a T4 to sacrum pelvis construct and reduction of the kyphosis. I was hoping to do an L1 VCR posteriorly, but everything was just so scarred in, I wasn't able to get into that space very well. So I took her for an L1 corpectomy through a thoracoabdominal approach, and then a stage 3 L5S1 ALIF with the Kabesh method to optimize or augment the fusion of L5S1. So these were her post-operative X-rays with the restored alignment. And then this was her at 2-year follow-up, where she fortunately did achieve a solid fusion. She does have a little bit of PJK at the top, though that's been stable for almost the 2 years now. And interestingly, she did develop progressive L4 and L5 fractures, though she did go on to fuse throughout that entire construct. So even with optimization, her bone health is still far from perfect, but was enough to get an adequate fusion and stabilization in her case. So starting with, what is osteoporosis? And so it's defined as a decreased bone mineral density, bone mass, or the quality or structure of bone that leads to a decrease in bone strength and can increase the risk of fractures. But how do we use this clinically? So I think thinking about it in terms of bone strength is probably the most helpful. And this is either the ability of our instrumentation to hold up, or looking at fracture risk. And so bone strength is really a mixture of bone density, bone quality, as well as bone geometry. So the quality relates to the microarchitecture of the bone, the collagen structure, mineralization, as well as turnover. And then bone geometry also plays a role, as smaller bones break more easily. And if you have sagittal imbalance, that can place greater stress on the bones and lead to a higher fracture risk. And so that's part of having a compression or burst fracture begets other fractures, both because it's a marker of poor bone health, but also because there's some biomechanical stress on some of the adjacent levels as they develop more of a kyphosis. So osteoporosis is incredibly common in our spine clinics. A lot of the risk factors that bring patients into CS are the same things that are risk factors for having osteoporosis. So age greater than 65, having a kyphotic deformity, smokers, alcoholics, chronic steroid use, sedentary lifestyle are all significant risks. And interestingly, if you have a patient who has more than a 2-inch height loss, they have a 4.4-fold increased risk of having hip osteoporosis, and that goes up to almost 10-fold if they have more than a 3-inch height loss. And that's true of a lot of our sagittal plane deformities or coronal as well, where they lose height. But it's also a significant marker that you need to investigate for bone health. So DEXA is probably the most common way and is still considered the gold standard for diagnosis of osteoporosis. And this is basically just using X-ray technology with a source and a detector, but it's sending very low radiation doses compared to a standard APM lateral lumbar X-ray, and it has very little scatter radiation to the technologist. The problem is DEXA is really just averaging what it's seeing on that X-ray. And so it usually leads to a significant overestimation, at least when we look at the spine numbers, because things like degeneration, where you get end plate sclerosis, or osteophytes lead to a significant overestimation of what the bone is, because those are going to make your number much higher. Also, fractures, soft tissue calcification, any sort of overlying objects can overestimate it. You get underestimation with lytic bone disease, laminectomies, as well as having very small bones. So based on that, at least for our patients, the DEXA and the spine numbers are fairly worthless, unless they're already giving you a diagnosis of osteoporosis. Then that's kind of the only situation I find them helpful. Otherwise, I like to look at the other regions, either radius or some of the hip measurements. And so the World Health Organization definition of osteoporosis is based entirely on DEXA testing, and it's based on a statistical T-score. But the reference standard is a young Caucasian female. So this may not be applicable to other races, as well as not ideal for men and for elderly women. And so it's based on the lowest T-score. So if it's greater than -1, that's normal. -1 to -2.5 is osteopenia. And if it's lower than -2.5, it's osteoporosis. If you add in lower than minus 2.5 in a fracture, that's considered severe osteoporosis. But the challenge is that this only explains less than 50% of fractures, and it really doesn't provide you with treatment decisions or any sort of algorithm. So the Ganont method for compression fractures is kind of what's used to identify a fragility fracture. So grade 1 is at least 20% height loss, and then up to a grade 3 with more than 40% height loss. And so these are very useful to look at on any sort of x-ray that you have, or doing a vertebral fracture analysis to specifically look for any of these compression fractures, as that gets you to a diagnosis of osteoporosis. This looks at your fracture risk relative to your T-score. And so you can see, especially in that -2 to -3 range, or -1 to -3, there's a lot of variation. And it's not until you get down into that really severely low scores, less than -3, that you get an exponential increase in fracture risk. And so there's still a considerable number of fractures in that -1 to -2.5 range, or even 0 to -1, which is considered normal. So clearly it's not very helpful in identifying those patients. And again, this looks at the distribution of fractures. And so although they're much higher distribution as we get to the very low T-scores, there's still a number in even the positive DEXA range, but particularly in that low, normal, and osteopenic range.
Is it a totally different spot? No.
Oh, and then again, the greatest risk of having an additional fracture is having a single fracture. And so for the patients with the lowest T-scores, their risk of a fracture was 25% if they had a prior fracture, compared to 7% if there was not a prior fracture. So what are the different ways that we can measure bone health and bone fragility? So there's the DEXA-derived ones with aerial bone mineral density and a T-score based on DEXA, and then a trabecular bone score, which we'll talk about in a little bit, and then vertebral fracture assessment, where it's just converting that DEXA to a very low radiation X-ray to look for fractures. And then the FRAC score, which is a survey that I'll show you in a little bit, and that can be combined with bone mineral density as well as TBS scores to get a more clear picture of what your fracture risk is, both for major osteoporotic fracture as well as hip fracture. And then the newer ones are the CT derived, where they're doing direct measurements on the spine with quantitative CT, or newer measurements based on a heel. Hounsfield units, which are a very easy way for us to opportunistically measure bone density. And then a virtual stress test, which is a company out in California, ON Diagnostics, who does a CT bone strength assessment, which is an FDA-approved test for it. So this is the trabecular bone score, and really what it's looking at is how homogeneous the organization of the bone is. And so it's just looking at a pixelated structure based on the DEXA. And so if you have severe osteoporosis and loss of your trabecula and significant heterogeneity within the cancellous structure, you get a much more disorganized pattern and a lower TBS score. And so really it's the equivalent of looking at what the organization is. So if you have a bunch of metal that's randomly organized, it has very poor biomechanical strength to support anything, versus in normal bone, where it's a very well-organized lattice structure, at least a significant biomechanical strength. And so this is how the FRAC score works. So it's really just based on a questionnaire looking at age as well as different risk factors for osteoporosis, such as prior fracture, a parent with a fractured hip, smoking, glucocorticoid use, rheumatoid arthritis, and alcohol. And then it gives you this risk of major osteoporotic fracture and hip fracture. And then you can tailor that further by adding in the BMD measurement or T-score, as well as the TBS scores. And so it gives you this risk. And then if the major osteoporotic fracture risk is above 20%, or the hip fracture risk is above 3%, then that is diagnostic of osteoporosis. And that's accepted by all insurance companies. So that is a great tool to look at, particularly useful for patients with osteopenic T-scores based on the DEXA. And then Hounsfield units are the one that we've been using more commonly. And this is a dimensionless unit that's calculated based on the radio density of the tissue, and increasing values reflect more dense tissues. Lumbar CT is obtained for all of our patients preoperatively for anyone who's undergoing a fusion, and it takes about 10 seconds to calculate these per level, if that. And so we usually, for research studies, we do them at 3 axial levels at the superior, middle, and inferior aspect of the vertebral body and average them together. In practice, we usually just take one around the pedicle level at the different levels I'm instrumenting. For my purposes, I actually try and look for what the lowest ones are and then order a CT bone strength targeting that level to get an FDA diagnosis if I don't have any other way to get to osteoporosis. But based on these have really been popularized by Paul Anderson, who's been a great collaborator on some of our projects. And he identified that the cutoff for osteoporosis is around 110 based on some biomechanical work that he did. And he actually got the insurance providers in Wisconsin to, or at least in limited cases, to start accepting Hounsfield units for a diagnosis of osteoporosis. We unfortunately have not been as lucky here. And then this is the CT bone strength, which is that test from ON Diagnostics. And so I found that it seems to mimic what we're getting on Hounsfield unit measurements, although and we've tried to do some studies to compare the two, but of course the founder of the company is very resistant, as his technology is definitely a lot better than measuring a Hounsfield unit and gives you much better information and is FDA approved. So does not want to make it look like it can all be replaced by a Hounsfield unit, which I definitely agree it cannot. It's a great test that gives you the vertebral strength based on a virtual analysis, and then we'll classify it as fragile, low, or normal, and then can calculate the spine trabecular BMD as well. And they can do this in other sites of the body as well. And so this was a paper we did in collaboration with Paul Anderson's group in Wisconsin, just looking at 244 patients undergoing spine surgery at our 2 academic centers. And all the patients had to have DEXA, CT, TBS scores, and FRAX. And we just wanted to look at what the rates of osteoporosis were based on different guidelines. So if we just use the World Health Organization guidelines with a T-score of less than minus 2.5, only 25% of the patients in this cohort were diagnosed with osteoporosis, which is still a substantial number. But if we looked at Hounsfield units less than 110, it was 37% of the cohort had osteoporosis. If we use the National Bone Health Association guidelines with T-score less than minus 2.5, history of fragility fracture, or the FRAX criteria for osteoporosis, it was 75% of the patients had osteoporosis. And then if we expanded that to including Hounsfield units less than 110 as well, it was 82% of the patients with just degenerative conditions undergoing surgery had osteoporosis. So it's clearly a very prevalent problem in our patient cohorts. And so what is the significance of bone density in spine fusion? So these were some of the studies that we've done looking at this. And so we looked at the lumbar Hounsfield units and looking for osteoporosis-related complications more in smaller level spine surgery, so up to a 4-level fusion. This was looking for fractures or instrumentation failure within the first year. And originally, the study was actually done using T-score data. And the most interesting part of that was that they identified the highest risk in the osteopenic group, where 40%, there was a 40% rate of osteoporosis-related complications compared to only 36% in the osteoporosis group, though it was much smaller. And it wasn't clear why that was. So then we started looking at Hounsfield units within this group as well, and that was a much stronger predictor of complications, as they did have lower T-scores in that group, but significantly lower mean Hounsfield units. And for every 25-point decrease in Hounsfield units, there was almost a 2-fold increase in mechanical complications. This was one we did looking at subsidence following ACDF. And again, there were some other risk factors like diabetes, but to have more significant subsidence, the patients had significantly lower vertebral body Hounsfield units than the cervical spine. The cervical numbers tend to be much higher, usually in that around 300 plus, 300 to 400 for a normal spine compared to the lumbar spine. And then this was a more recent study we did looking at subsidence in T-lifts. And again, the L3 vertebral body Hounsfield units were a significant predictor of subsidence, both greater than, or severe subsidence greater than 4 millimeters. And then, of course, we're all worried about PJK in our deformity patients, which is a significant problem that no one's really been able to solve completely, although I know Larry Lanke has said he hasn't had any PJK in the past 2 years. So maybe he has it figured out. So this was a paper we did looking at Hounsfield units at the upper instrumented vertebra and PJK in patients with a UIV near the thoracolumbar junction. And so interestingly in this, the mean Hounsfield units of the UIV or UIV plus 1 had an odds ratio of 0.94 for PJK. And that doesn't seem like a huge odds ratio, but that's actually per Hounsfield unit decrease. So when we look at 20 or 30 point drop in Hounsfield units, it becomes a very significant risk. And then this was looking at different classifications based on Hounsfield units. So if we looked at the patients with Hounsfield units above 160 at the UIV and UIV plus 1, there was only a 12% risk of PJK or PJF. But if these dropped to less than 110 at those top levels, it was over 60% of the patients at PJK or PJF. And then we found the optimal cutoff to minimize the risk was around 120 for the Hounsfield units. This was a similar paper we did looking at a UIV in the upper thoracic spine, generally T2 to T5. And again, the average Hounsfield units at the UIV and UIV plus 1 were a significant predictor. And then looking at a similar cutoff, again, the Hounsfield units increase as you go up the spine, but if they were above 195 at the top level, there was only a 7% risk versus less than 145 where we had a 56% risk. And again, we found the optimal cutoff was around 160 in the upper thoracic spine. And so if we know that this is a significant risk, what can we do about it? And so pharmacologic intervention is really the key for these patients. And so first, you want to make sure that they have adequate calcium and vitamin D. This is the typical dosing we use for vitamin D repletion, where if they're severely deficient, we treat them with 5,000 units a day for 8 to 12 weeks. And then these are the established treatments for osteoporosis. And so they're generally the bisphosphonates, which are very commonly used and are considered an anti-resorptive that prevent the bone from breaking down. The selective estrogen modulators, raloxifene, and then denosumab is a newer one that's given every 6 months, which is an antibody and RANK-L inhibitor. And then teriparatide and abaloparatide are recombinant parathyroid analogs that are fairly similar and are daily injections for up to 2 years. And then romosozumab is the newer one that's been on the market now for, I think, about 5 or 6 years. And this is a monthly injection that's an antibody to sclerostin. So again, the bisphosphonates are probably the most common one and have been around for many years. And these are considered anti-resorptive agents where they just inhibit the osteoclasts. And so they're blocking down blocking the breakdown of bone. Since bone is really constantly getting remodeled, you can think of it kind of like getting your roof replaced every certain number of years. There's a constant balance of the osteoclasts breaking down the bone and then the osteoblasts synthesizing new bone. And then denosumab is the antibody to RANK-L that's given every 6 months. And this one works by preventing the development of the osteoclast precursor cells into mature osteoclasts. The problem with this one is once you stop it, all of a sudden you have this huge backlog of immature cells, and once you stop it, they all suddenly mature into osteoclasts, and you get a sudden release of these cells that significantly break down bone. So if patients are started on this one, it's very hard to transition them to one of the anabolic agents. And then these are the mechanisms of action for what we consider the anabolic medications, which are the ones that build up new bone. So again, teriparatide and abaloparatide are parathyroid hormone analogs that act on that PTH1R receptor. And then romosozumab is the sclerostin antibody, and that acts through the Wnt signaling pathway. And this has some anti-catabolic function as well. And so one of the concerns with bisphosphonates has been their influence on fracture healing, and then they can prolong union times of distal radius fractures. Now, that hasn't really been shown as much in the spine literature, but there is still some resistance to patients using these at the time of surgery. I've kind of used these all the way through surgery and perioperatively and haven't had any issues in terms of our fusion rate, though the spine data is pretty limited in this area. Now, bisphosphonates do have side effects such as atypical femur fractures and osteonecrosis of the jaw, but their relative risk when compared to preventing the hip fractures, the benefit it goes significantly in the benefit ratio. And then what if we look at the anabolics and anti-resorptives? So this is looking at the median percent change in bone mineral density from baseline. And so comparing placebo, romosozumab, which is the orange line, alendronate, and then teriparatide. And so based on this, at 1 year, romosozumab had the greatest increase with almost a 12% increase from baseline in bone mineral density. And teriparatide also had a significant improvement, but this was only about 7%. And then looking at volumetric changes of both the trabecular and cortical bone. So teriparatide has fairly minimal effects on the cortical bone, but significant effects on the trabecular bone. Whereas you get, with romosozumab, you seem to get effects on both areas with trabecular and cortical changes, which for us has important implications as the pedicle screw is about 60% of our fixation, and that's highly cortical bone. And then what about if we transition to romosozumab? So this is where the order does matter. So if you look at patients that were started on denosumab, which is that gray bar at the bottom, and then you compare it to ones that were transitioned to or bisphosphonate or teriparatide and then transition to romosozumab, the naive patients had the greatest percent change, again, around 12 or 13%. But if they were started on denosumab first, this knocked it down to only a 3% increase. So it's very problematic when patients are started on denosumab as the first-line agent. And a lot of the primary care doctors prefer this one because it's every 6 months, so it's very easy for the administration. But really, bisphosphonates, you get some knockdown of the effects, but it's not nearly as great. And I think a lot of that is due to the fact that you're just getting significant release of those osteoclast precursor cells that then go down to break on the new bone that you're depositing with romosozumab. So anecdotally, on a couple of patients now, when we've had to make this transition, our bone health endocrinologists have started just keeping them on the denosumab wall, giving romosozumab as well, although that's very anecdotal and completely off-label for both of them. And then there is limited data on the effects of teriparatide in accelerating lumbar fusion. So this was one of the older studies in Japan, where they're probably much farther ahead of us in bone health optimization. And so they had 57 patients that got resendronate or teriparatide and treated them 2 months before and 8 months after surgery. And there was an earlier and more robust fusion in the teriparatide group. This was another study out of Japan where they looked at the insertional torque of screws and had a significant increase in this, even with only 1 month of treatment. And then this is the impact of teriparatide on complications out of the Linke group. So this is really the only study we have in deformity showing any benefit to teriparatide group. And so they looked at patients that were treated versus had osteopenia, and then patients that were treated for osteoporosis with teriparatide versus their normal bone density group. And really by treating them with teriparatide, they got the risks of 2-year reoperation, pseudoarthrosis, pretty similar, as well as PJK, pretty similar to both the or probably better than the osteopenia group and pretty similar to the normal bone mineral density group. So this clearly has significant benefits in our practice. And the benefits may be even higher with some of the newer agents. And so this was an animal study we did looking at fusion rates with teriparatide versus control. And there were similar overall fusion rates, but a significantly higher fusion mass volume in the teriparatide group. And then when we looked at combining this with low-dose BMP, there was some synergistic effects between teriparatide and BMP on the fusion mass with kind of these massive fusion masses, which you do get already with BMP, but they were expanded with the teriparatide treatment. And then, so again, if Hounsfield units are very predictive, can we change them? So this was a review we did of 50 patients at Mayo who had a mean of 21 months of treatment with teriparatide, and then compared CT and DEXA before and after therapy. And so looking at the overall Hounsfield units average from L1 to L4, there was a 22% improvement in Hounsfield units with the 21 months of treatment. And we did see an improvement in the bone mineral T-scores, but there was very minimal change in the femoral neck T-score with teriparatide. And that does mimic a lot of the other data that's been out there. Then this was looking at different regions of the spine and how we can change the Hounsfield units. And so again, the cervical start with much higher, so we didn't get a significant improvement there, although there was a trend towards an improvement. The thoracic spine had a 25% improvement, and then both lumbar and sacral were around 20%, and we did get some improvement in the ilium as well, although again, that wasn't significant with the smaller numbers. But some of the worst Hounsfield units are actually in the sacral ala, where they can be negative, which means less dense than water from fatty infiltration of the bone. And that has implications for where we have our fixations, and especially some of the SI fusion devices, either if you're doing a lateral iliosacral trajectory, basically the tips of the screws are in fat, and so it's very hard to get great fixation. And so some of the newer devices with a standard S2 alar iliac screw may have benefit where you're getting much better fixation distally within the ilium and still stabilizing it with your S1 screws. And then this was a more recent study that we did comparing bisphosphonates, denosumab, shorter term teriparatide treatment of 3 to 12 months, greater than 12 months of teriparatide, and then 3 to 12 months of romosozumab. And so we saw pretty much no change in Hounsfield units with alendronate or denosumab. A slight increase, though it wasn't remotely significant, with shorter term teriparatide, and then fairly similar improvements with both greater than a year of teriparatide and shorter term romosozumab treatment. But our romosozumab patients would tend to be starting off in the worst area as well. So this seems to be very effective, either treatment, but probably faster benefits with romosozumab. So what are the takeaways? So teriparatide and abaloparatide have had wide adoption and have been around for many years now, and clearly have improved fixation strength, and some studies have shown faster healing and higher fusion rates. Typically, I try and initiate a minimum of 2 months before urgent surgery, but really, if they really need something urgent like cervical myelopathy and have severe bone, I try and use romosozumab, as it does have faster benefits. And ideally continue to the full treatment of either of these, whether it's 2 years for the recombinant parathyroid analogs or 1 year for romosozumab. Our data has shown that romosozumab may be even more effective than teriparatide and abaloparatide, but that's a limited data set. So hopefully that will continue to be more explored. I think it's critical to maintain some time for treatment after your surgery. Some of that's based on our animal studies that show improvement in our fusion mass, but it's also an osteoporotic patient is going to deposit an osteoporotic fusion mass. So as I've been farther in my practice, patients that I would have deemed to be solidly fused and kind of unquestionable on the CT come back with a rod fracture and kind of a fracture through the fusion mass 6, 7, 8 out now. And I think that's all because we usually say the rods aren't doing much once the bone is healed, but it's an osteoporotic fusion mass, and if it's just along the posterior elements, there's probably still a little bit of flexion across there, and so eventually you can get wear and break of your rods in the fusion mass. So really getting your fusion mass as strong as possible is important in these to prevent those late and long-term failures. Another critical thing to consider is that we really need to own the bone, which has been Paul Anderson's big initiative. And so we all get called for the little compression fractures that may or may not need bracing. But the most important thing we can do for them is get them referred either to our own clinics if we have a bone health optimization program, or to endocrinology to at least get started on bisphosphonate therapy, as that's going to minimize their risk of having additional fractures and preventing them from becoming that patient that comes in with 5 compression fractures and now a horrible kyphotic deformity, plus severely poor bone health. And then lastly, that the medication order is critical, and beginning with some, especially denosumab, makes others much poorer options. So really, that's the one to keep patients off of as a first-line agent. And the last thing to consider is all the anabolics need to be transitioned to an anti-resorptive agent after you're done with either that 1 or 2 year treatment, or you lose all those beneficial effects over 6 months. So whether you're transitioning to bisphosphonates, or denosumab is also a great one to transition to afterwards to be used as a maintenance medication. But that's the most important step that does get missed. So these patients really end up with lifelong treatment. Oftentimes with denosumab, they end up with permanent treatment. With bisphosphonates, they'll usually do a 5-year, treat them for 5 years and then do a drug holiday and then reassess if they need to be restarted on it. But I'd like to acknowledge all the team members that have been critical on these. So Nikita has helped with a lot of this work, and of course has been a fundamental. Tony Mikula spearheaded a lot of these projects and is fortunately joining us back on staff next year. So thank you.
That was awesome. Thank you. Thank you, Ben. Do you think we'll ever get to a place where we can assess risk, stratify them, and then put together a treatment plan that's more patient specific relative to their particulars of bone health issues?
Yeah, I mean, I think that would be the fantastic eventual step, would be incorporating some model. I mean, similar to a FRAX score, where we have a model of what their mechanical complication risk is, or risk of pseudoarthrosis after our surgery, and then have a similar one for patients that are not on an operative trajectory that just need it for fracture prevention. And then incorporate things like some of their different lab values and other medical risk factors. Like, for instance, there's a warning with romosozumab for patients with cardiac disease because there were slightly higher cardiac events. Although I think now there's been a massive number of patients treated in Japan with that drug, and doesn't seem to be as much of a global cardiac risk with it. So that may change in the coming years. And then patients with hyperparathyroidism can't be treated with the parathyroid analog. So sometimes you are limited by the patient's pathology. And then the original parathyroid studies, any sort of there was a higher risk of osteosarcoma in rats when it was used at pretty high doses. So now that one's been on the market for over 20 years, and it doesn't seem to have a huge oncology risk, but people are still, and I think they removed the black box warning a couple of years ago, but people are still very reticent to use that in the oncology population who has very poor bone health.
Most of our treatment algorithms right now, medications, and how we decide we're going to use them over time are sort of dependent on this lousy proxy of bone density. We're using a 3% change, 7% change, when I think we all agree there's clearly a bigger mechanical differential that you get. So there's an architectural improvement that we're not able to measure with easy technology access. What do you think we need to do going forward to get a better sense of the real implications of these medications and how to monitor their effects? Is it the technology that you're sending out to get more of a bone architecture sense?
Yeah, I mean, I think that CT bone strength is very helpful for looking at those changes. I mean, actually, I got started in this area because Cal Kabesh had been pushing this probably starting 15 years ago and was pre-treating everyone from when I was an early resident. And there wasn't much going on at that point around the country. But I used to always ask him how you would retest to make sure they're strong enough for surgery, and he would always just say, "Oh, the bone feels much better than it should, so that's why I never retest anything because the DEXA doesn't change." And that's how I actually got started down looking at Hounsfield units when I first started on faculty. I said, well, maybe that's some way we can quantify changes, and then we've kind of carried it from there. One of the things we're looking at within Mayo right now is they have newer CTs called photon counting CTs, which give incredible detail on the bone and the microarchitecture with the same or even less radiation than our current CTs. And so we have a photon counting CT. I think we may have 2 now. And they had done some studies looking at the wrist bones where you just get incredible granularity. So we're doing a pilot study looking at vertebral body changes because you can really easily measure cortical changes within that as well as the individual trabecula and get much more detailed measurements similar to what we'd get on a micro CT for research studies. So hopefully that will be the future. And I would guess over the next 10 to 15 years, that'll become the standard of care CT that's at every center.
Do you think we'll be able to move that over to MRI instead of CT radiation-based stuff?
Unfortunately, like all the work we've done with VBQ, it has much poorer correlations with bone health compared to CT. I think there's just so many confounders in tissue edema and surrounding changes you get on the MRI that it's not really giving you a great look at what the actual bone architecture is. Now, maybe that technology will increase, but I think there's so much artifact that we haven't had great success, especially when we compare it to even just Hounsfield units. I think the goal would be something
that may
like
be the
DEXA,
future
where
of
it's a
CT
very
then, right?
low radiation. Yeah, we can have like DEXA, where it's a very low radiation system where we can get a granular measurement, and that may be the future with photon counting CTs.
Yeah, it'd be awesome to have something that you could have in the office, like like you have these CTs that are just for an extremity, right? Like there's like a wrist CT that you can stick in your office.
Right.
It would be pretty awesome to have something like that you could, that didn't require a whole room and
Yeah, and
all
actually
that kind of stuff.
there is a company out there that I think has an FDA-approved device for actually directly measuring the bone strength. They have this little micro indenter that they do indent the tibia with, and so we've had some discussion with them about trying to use that for direct measurements of the bone intraoperatively, but perhaps that could be a percutaneous assessment as well.
Osteoprobe.
Yeah, exactly.
Well, I can't thank you enough, Ben. Awesome to have you join us for the Monday morning.
Yep. Yeah. Thanks for having
Appreciate
me.
it very much. All right. Have an awesome day.
Thanks,
Thank you.
too.